Good morning. I'm John Markoff, and I have covered Silicon Valley for the New York Times, and now I write for the science section, usually not about medicine, more about computing, and it's an intersection with science. And Esther and I have known each other for a long, long time. I guess this is by way of introduction. I think Esther began as a journalist like I did, and she has been a conference organizer where I met her, I think, 30 years ago at PC Forum, which...
82, yeah.
82.
Wow.
Time flies. She's been a newsletter editor and now an angel investor and on a wide variety of nonprofit boards. And it's odd because when I first met Esther, she was in my chair, and so we've flipped. And I've interviewed her many times over 3 decades, but it's always been on the telephone, never in public. I don't think I've ever interviewed you in public. So, one of the, given that you started, you sort of like I did, grew up with the personal computer industry. And I was thinking about your trajectory your trajectory of your peers, if you will, who, by and large, all seem to be investing in social networks these days, or
videos
probably
for rich white guys.
Yeah. So you didn't go in that direction. Why not?
Well, I started out, and in the end, I hope this is more about what I think than about me, but how I got there.
Yeah.
I was one of the altar boys of journalism. I was a fact checker. And whatever you think of the religion or the church of journalism, the religion itself, truth, asking questions, not being afraid to be dumb, but also trying to find out new stuff rather than just tell old stories, is what I've done ever since. So I always did things that were new and kind of unpopular. But undeservedly so, at least that's what I'd like to think. So started with the PC and then the internet, and how many of you have studied math? Even though we asked to have the lights up, it's still impossible. Okay, so you probably had a math professor who at some point scribbled some proof on the board halfway and said, okay, this proves the thing. The remainder of the proof is left as an exercise to the reader. And I liked the first part, not the remainder of the proof, but the beginning of the proof. And lots of stories, but maybe 10 years ago, I began to realize one of the most interesting unsolved problems is healthcare, health, medicine, human behavior, all these things. So in one sense it was that. In the other sense, it was very specifically, I was at a Renaissance weekend conference. And we have e-patients. There they have everybody. It's a very inclusive thing. It's mostly high-powered business people and their families over New Year's. The idea was to make people behave better, and instead of drinking themselves into oblivion, to think about the future and be with their families and behave right. So everybody gets to sit on a panel. And I went to a panel on healthcare, which I didn't know that much about. There were about 20 panelists, hospital administrators, surgeons, nurses, ER doctors, life insurance company executives, 20 people who'd been mostly in the healthcare system for years. They were all well-meaning, intelligent, wanted to take care of patients, wanted to do good. And there was an audience of 3 people, me and 2 other people, I don't remember who. And they were all, each of them said what they had been saying probably 100 times. Each of them had heard at least 1 or 2 of the other people talking 20 times. They were all about the deficiencies of the system, the misaligned incentives, how long it takes to get any invention into practice, how we can't change, let alone human behavior, we can't change doctors' hand-washing behavior. It was tragic. And I thought, gee, in my business, the internet, and startups and venture capitalists, you'd have had 3 guys with startups there. You'd have had 7 people with new drugs. You'd have had a couple of investors, and people would be excited about doing something instead of fundamentally depressed. So I went and ran a conference called Personal Data Something, and got really interested in this, and that's ultimately how it got started. Unlike most people, I didn't have some personal experience that made me, I've been extremely lucky. So it was more intellectual, quite honestly, but I'm a passionate person, so.
And we have about 45 minutes here, and we're going to talk for about a half an hour or thereabouts, and then I'm going to try to bring you all in too. So think of questions as Esther talks that you'd like to pursue with her. So what's the logic between sort of that experience and if you could frame that in terms of your current interest as an investor and how those two things tie together? And I think maybe we could start. When we first talked, you mentioned you see the world in 3 markets, or you see this world in 3 markets, and that was. And the question I wanted to ask: are you only interested in the one that it seems like you're?
Okay, well, I'll make the bridge. So first, my reaction at first was, well, just blow the thing up. It's so dysfunctional, but that would probably cause more damage, and it would take too long to repair, but definitely erode it from the edges, infiltrate the cracks. And if you saw what happened in the telephone business, the trick was not to blow AT&T up. They tried to, and then they just created 7 or 8 mini AT&Ts. The thing that really changed telephone service was the mobile companies, which were new companies. So the idea is come from outside and replace it rather than blast it to bits. So the 3 markets are indeed the traditional healthcare market. Everything, doctors, nurses, institutions, payers, insurance companies, clinics, pharmas, maybe drugstore chains, whatever. Just it's a really big market. Investors know about it. There's lots of public companies, and they have their own set of incentives, even though they're misaligned. The more people are sick. I remember reading a headline, flu season starts, drug stocks rise. Isn't that great? The second market is the market for bad health. It's, forgive me, the muffins you were served on Friday morning. It's alcohol, tobacco. You could argue it's videos that keep you sitting in your computer instead of out exercising. It's recreational drugs. It's everything. It's too many elevators for people who can walk. That's the market for bad health. Very prosperous market. Lots of advertising goes into making people eat bad food. And not just advertising, but actual product formulations. Processed food that tastes really good. It's sweet, it's salty, it's addictive. And then the third market is the market for good health, which wasn't really much of a market because there wasn't a way to monetize it. How do you monetize somebody going for a walk? There's sports clubs, there's gym equipment, but until now, with the advent of sensors and social networks and the internet, suddenly, yes, it is possible to create something that you can sell to somebody and make money off to help them become healthy. And that's really exciting.
And are you focused on just that one? Where does
personally, I'm focused on space travel and human I'm focused on things I think are exciting. So I'm an angel investor. It's my own money. I don't need to apologize when I waste it. So in theory, I'm focused on helping people change their own behavior to become healthy. But in practice, I'm kind of susceptible to anything.
Some examples. First of all, broadly, how many health-related investments have you made?
Probably 25 or something like that.
So there are many more than I know.
HealthTap, Health Rally, Health Engage, Health Village, which became Medivo, Omada Health.
And between the healthcare and the health market, have
Yeah.
you, like some of them, I can't figure out which bucket to put them in. Do you stray over into the healthcare market? Or
Yeah,
you do?
I've got an investment in a company called Tokagen, which is a traditional company with they hope, an effective brain cancer treatment. Applied Proteomics, which is Danny Hillis's company for biomarkers. And then Omada, a lot of them are, in my world, the traditional healthy behavior companies.
Yeah. Well, so once again, to take advantage of your sort of long view perspective, I was thinking about this sort of explosion of companies.
Yeah.
And then I was thinking about timing, and I think we probably both remember, although I don't know how many people here remember this thing we used to call the AI winter. And after that, there was a period called the dot-com period, and where there was these explosions of companies. And I continually go back to our friend Paul Sappho, who of the many interesting things he said, he once said, "Never mistake a clear view for a short distance."
Yes.
And so I was just wondering if you have sort of parallels to draw between those eras in terms of investments and where we are now.
So the AI winter, AI, artificial intelligence, it's everywhere now, but nobody notices it because it's inside other things. Somebody defined it as whatever doesn't quite work yet.
Yeah.
The moment it works, it's not AI. It's an expert system, or it's Siri, or it's
a car that drives itself.
Yeah, turn-by-turn navigation, or even something that will monitor your vital signs and send an alert. But what intrigues me is it's both I tried to create this meme that flopped, but it's still a good one. There was the Homebrew Computer Club, which was a bunch of guys fiddling around with Ataris and circuit boards and things like that ultimately became personal computers. And now we have homebrew health. People rigging up their own monitors or buying a Fitbit but doing their own software. People say, "Oh yeah, this is cute," but it's only these weird geeks. And then suddenly, once the stuff becomes usable and friendly and doesn't crash all the time, normal people start using it. The issue here is payment. So people are used to paying for personal computers and devices and so forth. They're really not used to paying for health. It's sort of like, yes, I'll pay $10 for a latte, but someone else is supposed to pay for my health care. And things change over time. People now pay online for music, not all the time, but at least some of the time. But I think it's going to go in waves. First, you have people who will try anything, and they'll even pay for it. They'll build it themselves. Then you have employers. Employers are really and there's only, who in here is or ever has been an HR person? Wow. Those are the people you all should be talking to, because those are the people who have an interest in people's health. The medical world, even though the people in it are mostly dedicated and so forth, they're interested in people's illness and finding problems to solve. Employers want people to be healthy, not simply because they want to avoid the costs of health care, but because they want to avoid the costs of ill health. They want their people to be healthy, motivated. They want their kids to be in school, not in the hospital. So they are willing to take a flyer. If something looks as if it's going to work, or if it's going to motivate their employees, even if they don't become healthier, they become happier, they feel more cared for.
Is that Keyes? Which of your companies sort of fits directly?
Keyes is a company that it's got health games paid for mostly by employers that encourage people to form teams, exercise, lose weight, whatever.
And now, are you familiar with it? It's a Stanford professor who's in CS but not here, Balaji Prabhakar, who's sort of the work that he's doing is closest to Thaler and Sunstein's book Nudge.
I want to talk about that
okay.
later, yeah.
Okay. Later in with respect to, because it sort of fits, he's worked with corporations putting Fitbit on people and then sort of turning the Fitbit experience into a game. And
Yes.
Is this what Kies is doing?
More or less. Kies is agnostic, though they now have specific games and things they offer, but Kies is a platform for doing all this kind of stuff. Yeah. So anyway, the employers will pay even without so-called clinical trials or scientific evidence. If it looks good, they have playrooms for kids, they have coffee in the lunchroom. Why not give people Fitbits? And so they're going to be the second line of payment. And with luck, they will produce enough, if you like, regularized data. I'm in a company called Genome, which is kind of user-generated clinical trials. But if you want tens of thousands of people across the country and good data, employers will be able to provide it. Now, will they share it is another issue. But my hope and my clear view, but not necessarily the short distance, is that then the employer-generated data will ultimately be so clinically compelling that you'll start having insurance companies and governments and so forth paying for more of this.
And how far along is Genome? I looked and there's not a...
It's pretty early still.
Okay.
But it's exciting again.
And could you just talk about, patient-generated clinical trials, how do they connect to the clinic?
No, they're not clinical. They're,
okay.
Sorry, clinical was in quotes. They're patient-generated trials. Depending on the protocols and who's watching, you could use it for a formal clinical trial. But the idea is people getting together, patients like me, which I'm also in, is for really, really sick people. Genome is more for curious people who may be healthy, but they're curious about the effect of orange light on their sleep patterns, or does vitamin D do this, or if you have such and such a gene variation, are you better or worse at, there's a lot of companies now generating data. Genome is focused, again, it's a platform for almost any kind of data match with any other to see what the correlations might be.
We touched on AI, and I wanted to bring it up because I think when I was standing backstage, I heard one of the introducers talk about the impact that technology was going to have on the medical workforce, if you will. Does technology or will technology displace doctors?
So I think 80%, Vinod likes to get attention, and provocative statements are what make people talk about a concept at a conference, and that's a good thing. 80% is probably high, and it depends on what you consider the doctor's job to be. They may replace 80% of the doctor. They won't replace 80% of the nursing, the hand-holding, the counseling. Omada Health, which I'm also an investor in, is basically a platform for counseling, and it kind of elevates the personal touch. So there's the medical decision-making, and then there's the care, the nurturing, the listening. A good doctor will spend more time with their patients, or a doctor that has enough money not to be driven to the 7-minute appointment.
But you can look at technologies like Watson, for example, and you could think of deploying it as a form of triage in a sense.
Right. So there are other people who are much more engaged in this particular argument, but in the end, a good doctor listens, looks, asks the questions the patient doesn't volunteer. We heard this yesterday, Hippocrates, something along the lines of, it's important to look at the patient before you look at the disease. I'm mangling the quote. Somebody can say it better. But a disease doesn't operate in isolation. It's part of a whole body. There's interacting parts. if you wanted to sum up this entire conference and this entire field, it is interacting things are much more complicated than any of the things alone, including people's minds, including the thing we haven't talked about yet, which is all the social cues and interaction around people that generate their behavior. So the doctor is part of that. If a doctor volunteers or wants to look at the human person, it's going to take a long time before Watson really gets those cues. I mean, you can build a pretty good pattern recognizer tool, like ELISA, the famous.
Or to do pathology, perhaps.
Yeah, and certainly for pathology, looking at cell samples. But so here's an example. 15, 20 years ago, I started having an ache in my right leg. Not a pain, nothing localized, it just sort of hurt. It was just about when we met. I was in this office building on Park Avenue. It had a very heavy door to the ladies' room that you had to sort of push up against to open it. And one day I was doing that, I thought, maybe this is why my leg hurts. I'd been doing it for 3 or 4 months. I stopped doing it. It took about 6 months for the pain to go away. And it sounds crazy, but this is the amazing thing, how you do not notice things and you do not make correlations. I could have, had I been a little more conscious of my health, I might have gone to a doctor and said, "Doctor, I've got this pain in my leg." And he would have x-rayed it and poked at it and maybe, I don't know, done a biopsy of the bone or something. It was just because I was bumping it against the bathroom door.
Yeah. But in that direction, I mean, one of the companies that I was looking at that you're involved in that's sort of, I thought was close to Watson is in a weird way is HealthTap, which seems to be, could you talk a little about HealthTap? And I mean, you could have also sort of dealt with that by dealing with posing the question through HealthTap, couldn't you have?
Yeah, I would have gone on HealthTap. I would have said, "I've got a pain in my right leg." I would have gotten amazing thoughts about what it might be. Nobody would ever have said, "Do you have a very heavy bathroom door?" HealthTap is a very nice example. So HealthTap pivoted slightly. It was originally supposed to be more peer-to-peer, and then it became more patient to doctor, but it kind of gave you better access to doctors, and the doctors would, so it's more peer-to-peer doctor with patients' questions floating up. And
is it a business? That wasn't clear. Do you subscribe? Do you pay for the service?
It's monetized mostly through the doctors.
So you go to the doctor?
It's free to patients. It's a platform for doctors, fundamentally.
What do the doctors get out of it then?
Patients.
Oh, I see. Okay, so it's lead generation
and
it's like a sales tool.
visibility and credibility, because doctors who give good answers get rated highly by other doctors, and it produces a corpus of knowledge that's extremely useful. But the challenge here is still the data collection. I mean, not that a doctor is a data collection machine, but it's the ability to notice what the patient or a doctor who's been practicing for 20 years just knows things. They recognize patterns. The challenge now, and this is the big challenge that I want to talk about in general, there's just more medical information than any single person can know, any single doctor. Simply, there's too broad a range of known diseases. There are medical papers about all these things that they don't have time to read. So on the one side, the corpus of medical knowledge is much, much greater, and there is real knowledge in there if you can find it, and that's what Watson could be good at. But then there's also more and more information about a patient. There's the one problem now, which is I have 3 or 4 different doctors. They're giving me different medicines. I've got x-rays here and scans there and biomarkers somewhere else. They need to be put together, and then they need to be stuck into a database and then pattern matched against all the other people with the biomarkers and the therapies and the outcomes. And that's what computers are really good at and doctors are not.
And to that point, just personally, I mean, you a couple of years ago made your medical history completely public, I think.
Yeah.
How's that worked out?
Really boring. So for those of you who don't know, I'm subject number 3 of the Personal Genome Project. So my entire genome is up online. You can go look at it. I was expecting at least a few nutraceutical advertisements, but I think the market's too small because there's a few hundred of us in the Personal Genome Project, and it's not worth anybody's time. George Church, who's the number 1 subject and started the project, has in fact gotten interesting medical advice from other doctors based on his genome and other stuff put up. The most interesting thing is it's really easy for me or for anybody, if you have a little bit of money, to get your genome sequenced. It's really, really hard to collect all your medical records. And in theory, they're all online up there, but they're not, including...
So what was your story of getting that together? How hard was it?
I hired a summer intern who wrote to all the doctors I could remember. And, maybe got half the stuff. And then also I have all these medical records from Russia where I was training as a cosmonaut. And those are in Russian, and again, they're not available. And so, okay. And then I was was also examined in Galveston next to the Kennedy Space Center by the American NASA-related doctors. And I think some of those got lost in the hurricane.
Just an aside here, are you still interested personally in going to space? And what's the current plan? What's your avenue? This is totally off point, but
if Omada Health makes enough for me to make $40 million, I'm on my way. So space medicine is actually quite interesting, but
not space medicine. But I also wanted to ask you about so where's 23andMe these days? And you've talked about the complete genome. What about the samples? Can you demonstrate useful outcomes?
Actually, you should have been here yesterday to hear Ann Wojcicki. So I'm on the board of 23andMe. Most of you probably heard Ann yesterday with just a wonderful elucidation of the usefulness of 23andMe. In the past, we've been fairly circumspect about claiming medical benefits, and I would still say that most of the 23andMe users are benefactors. They're donating their data to research rather than beneficiaries. But if you happen to, like me, not react much to Plavix, or you happen to either under or over metabolize warfarin, or you are an undiscovered celiac, or all kinds of things, it is in fact extremely useful. You get information you didn't know, and it helps you make medical decisions. The reality, of course, is most people, they need to eat more broccoli and less candy, and they don't need no stinking genome to know that. But 23andMe might remind them, or the fact that they did 23andMe might be a sign that they're beginning to think about it. So but beyond that, I just think being educated is important. And in order to use 23andMe, you need to understand statistics, just like if you follow baseball. People can do it with baseball. I think they can do it with 23andMe.
Just a slight personal story, because I bumped into you early on, and I was an early 23andMe. We knew that my sister had a Mongolian birthmark, so we knew that there was a little bit of interesting lineage in my family. And in fact, when I was sequenced with 23andMe, it turns out I'm 2% Asian. So we confirmed family lore.
Right.
That's apropos nothing. So big data. I wanted to ask you about that as a term, in that it's generated by a lot of the companies you're involved in. And when did we make the shift from data mining to big data, and how much of big data is actually sort of a meaningful term?
Yeah. Oh, it's no more a meaningful term than data mining. The point I want to make, and then maybe we can do the Q&A even, but So as I said, there's so much data out there. There's a profusion of potentially collectible data about a person. Over time, your blood, not just your blood sugar, but all the different proteins and biomarkers, your microbiome in your gut. Some of you have probably heard Larry Smarr, who turned from a physicist into kind of a poster
Quantified
boy.
self icon.
Yeah. Right. And so the next thing that's happening is we can make much, much better predictions. In the old days, we had health insurance because you couldn't really tell who was going to get sick and who wasn't. And now there's a sea change. And yesterday, Liz Marie Collazo, the angry diabetic, got up and said, guys, it's not my fault. And I may be misquoting you, but I think that was essentially, and we don't like to go around being stigmatized. This is going to be a really big social issue around responsibility, prediction, who should pay. So another thing I do a lot of is spend time in Russia. If you talk to an older Russian person, many of them will say, it was easier in the old days. We never had enough stuff. We never had any choices. But we weren't responsible for things. And so we didn't have the possibility of regret. It wasn't our fault. We did what we could. We tried to live happy lives. But we didn't obsess about, could it be better? Should we have done something else? We had no power. So if you empower people, you also give them responsibility and you give them duties. And, all of you here, is it your duty to wear a Fitbit to know how many steps you're walking? Is it your duty to count the calories in the food you eat? Life gets more and more complicated, more and more pressing for the individual. People go around with other people laying burdens on them. You're sick, it's your fault. Should society pay for your treatment? We need to make those decisions, starting at the one end, death panels, and on the other, how do we work socially? Do we tax?
But what about the sort of lack of, you put this situation in front of us, then you have this, at the same time, a lack of medical certainty. I'll give you one example.
No, not everything's predictable.
Or the predictions, or the certainty changes. For example, we've been told for 2 decades that, PSA is of value, and it turns out it may not be of value. And
no, I'm not saying anything is... It's simply, we're moving from we have no choice, we can predict nothing, to a situation where we can predict a lot more. Whether we can or we can't predict or explain, we think we can. So we lay burdens on people lay burdens on themselves. It's just, what I'm trying to say is there's a huge change in all our thinking and all our responsibility and how society treats these things from, it was also nice being a woman 100 years ago. You only had to decide who to marry, and that was about it, And you had to do stuff, but you didn't need to be responsible. We're now responsible for taxes also. There are lots of things. Life is fundamentally more complicated. And it's not only medicine. You hear about people drowning in Indonesia. What's your responsibility there? People are being inundated with responsibility, decisions. And then, I'm just explaining how complicated it is. I'm not giving you the solution. Then you have, so you can say, well, I'm not responsible for my actions. It's really my parents that made me the way I am. We should go back to that. But society as well. If you really want to fix health in this country, you probably should start with school lunches. And certainly, again, with education about statistics, about healthy behavior, about exercise. And then you need to understand some people get sick. It's not their fault. And some people make themselves sick. Is it their fault or is it their parents? It's complicated. And there's the whole libertarian paternalism of Cass Sunstein and Richard Thaler and those people. We don't want to restrict people's choice. They can always buy 2 16-ounce sodas in New York City, but let's make the default the smaller soda.
So before we jump to the open group, you said that you had seen some things here that you were struck by, and maybe we could move to the sort of question.
Actually, one was Liz Marie.
Oh.
I mean, I just think it's not just like the social and moral, ethical implications of knowing more. And I mean, it used to be just doctors were responsible if they missed the growth on your leg. But now all of us bear more responsibility for our own health because, quote, we should have known.
So, I mean, are you a quantified self person? I mean, do you have worn a Fitbit, but I mean, would you do what Larry Smarr has done?
Oh yeah, in a minute.
Are you?
And I mean, one of the more interesting. So when I was 6, I think we all had chicken pox in my family, or my brother, my sister, and me. And my brother just cried and moaned, and according to my mother, I was quite cheerful and just counted the spots on my face. So I love counting, and my best indicator of stress is the number of emails in my inbox.
I saw that.
But
but how many people? I mean, realistically, isn't that going to always be a relatively small part of the population that sort of decides to do that?
I mean, again, you weren't here yesterday. 60% more or less counts something. If it gets easier, if it's automatic,
yes.
you get on the scale or something every morning and it says you did blah, blah yesterday. Then it's, well, what do you do with that? Do you feel motivated to run more, weigh less, eat differently? Do you see your C-reactive protein go up and down? Do you do something about it? Do you compare with your friends? I think there's going to be, it's not that weird.
It reminded me of, there's this dichotomy in Zorba the Greek between the man who lived every day as if he was going to live forever and the man who lived every day as if he was going to die tomorrow. I mean, it's sort of that kind of a philosophical choice, it seems like. And I'm skeptical that most people, I mean, if you could give people the scale that would give them all the answers, I think the scale would sell very well. But I'm skeptical that a large part of the population would actually sort of become more like Larry Smarr.
I think...
I'm wrong?
I think you're wrong.
Okay.
Yeah, I mean, people would like to be... Yeah, they're going to clap. People would like to be healthy. They would like to look better, feel better. Again, I think society needs to help them.
Yeah.
They need to serve healthy food at conferences. They need to serve healthy food at school. The restaurants need to offer better food and tell you what it is you're eating. People will, I mean, you have to be a nut not to every once in a while be lazy, eat chocolate. People need to understand that it's much easier to stop smoking. Could you just stop? I mean, if you can, but you don't need to make decisions every day. Whereas about food, about exercise, it never ends. It's a series of choices. But if people around you are encouraging you to make different choices, if you see the values more often, if your car reminds you to fix the oil or whatever it is you do, it's easier. And there will be, along with all the stuff I mentioned, the overburden of too much information and too many choices, there will also be help. Lots of, and people will pick the help they find most useful. They'll pick the services they find easy to interpret. I was talking to a guy selling scales, and he said some people, they don't mind if their scale says red, yellow, or green. They don't mind even if it sends a message to their doctor. but they don't want to see the number. The number scares them.
Yeah.
It's like too concrete and too something. But they do want the advice about where they're trending.
How far can you push it? What's your reaction to people like Ray Kurzweil and the notion of radical life extension? Is that an entirely different?
Yeah, that's entirely different. That's all about supplements and, I'm actually really relieved I'm going to die because there are certain parts of me that are wearing out and they don't need to last forever. In the same way, if I was going to live forever, I'd need to learn to speak Chinese, and there's so many things I would have to do. But knowing that I'm going to die, I just need to deal with the top of the list. And it sounds funny, but it's real. Dying is, as somebody said yesterday, the progress of science is one funeral at a time. We need to leave way for the next generation. And yeah, the old people hanging on too long is going to be a big issue in the next 20 to 30 years.
Yeah. Let me open it up to people who might have thoughts or questions for Esther about her companies or her perspective. Yeah, there's microphones. Okay.
Or space travel.
Please, and maybe introduce yourself as well.
Yeah, so hi, I'm Ian, and I'm a self-quantifier by prescription. So I have type 1 diabetes. So I'm given the tools to quantify myself, and what I've done is that I have publicized all my data since diagnosis, so every single blood sugar reading, and I found that helpful. So but the help I'm getting is mostly from other people, other patients, and I find that the medical establishment, they largely ignore the data, the data they prescribe me to take. An interesting finding I've done, so I have diabetes for 5 years, and I have a We Think scale for 1.5 years. So I've been able to correlate changes in my weight to fluctuations in my glycemic control. And I've also been able to correlate my A1C to my readings. So the point is that the data is telling me when I need to go to a doctor or not. So what are the business models you can use for getting patients who don't need to go to a clinic or who need to go to a clinic more often into the system? How can you monetize that when it is against their incentives?
Okay. If I understood right, so how you monetize, well, one issue is the doctors don't really care, and I guess in some sense the progress of medical practice precedes one retirement at a time. Forgive me, those of you who should not retire because you're doing a great job, but over time, and it's happening now in the US, kind of along with reform, but also independently, we really need to think longer term. And as I said yesterday, we need to quantify the costs long term versus the costs short term. Any insurer that expects you to be their patient for more than 3 years is really going to want you to be healthy. An insurer that's just funded by the government that doesn't really care because they're really just a vehicle for passing along costs couldn't care less. They'll pass along the costs of treating you. But if somebody has an incentive in keeping you healthy, and we're going back to that both in terms of employers and capitation and how the medical payment system is structured, that's going to change dramatically over the next few years. And so the challenge is to prove to them what works, and then they will have a vested interest in keeping you healthy because the costs of treating you are much less than the costs of maintaining your health. What's going to interest them is how do they, again, what I really want is the government to understand the costs of people being healthy or sick and start changing school lunches, building layouts, encouraging walking over driving, all that kind of thing. And in that way, in fact, the Google self-driving cars may not be such a good idea, unfortunately, because they'll make driving more convenient.
Thank you.
Thanks.
Yes.
Rick Weiss from BioCare. We're a lifestyle behavior technology company from Esther's hometown, Princeton, New Jersey. Kind of a continuation of that discussion, I wanted to hear your vision on the healthcare model going forward with the introduction of accountable care, and how does healthcare start involving prevention and wellness as part of the transaction and not a cost that they don't do because they're not getting a fee?
Yeah. Well, if I were designing things over, I would create a market very similar to the mortgage market, which doesn't have a very good reputation right now. But, put people into buckets of costs. So high cost, medium high cost, average, low, and then securitize them. These people are going to cost $1 million to treat. If you can treat them for $900K and they're healthy, you get to keep half the cost savings, something like that. And that's de facto what we're starting to do. There are two challenges here, of course. You've got to keep them healthy for $900K. You can't just let them be undertreated. And so it's not as if we weren't already totally monitoring how healthcare is delivered, making sure that, and we're doing it ineffectively. That's a reality. I don't think we'll do it any worse if we do it according to accountable care rather than the current fee-for-service model. And one way or another, though perhaps not as clearly as the mortgage market, that's beginning to happen. It's imperfect.
So more like a capitation model then?
Yeah.
So ACOs are a good thing in your mind?
Yes.
Great.
They're not perfect, but it's not as if what we had before was perfect.
Yeah, it's early on.
Yeah.
Hopefully they'll morph into something better at the time.
Yeah.
Thank you.
Sure.
We have time for a final question.
Yes, it was a very inspiring panel. Thank you very much. I'm Okar. I'm the president of Keynote Health, which is a spin-off company from University of North Carolina. And we developed a platform for patients to reach out to the nurses. You talk about AI, we have expert systems, machine learning, but we include the nurses in the equation so the patients can get advice from them directly. So what do you think about that, using the high-tech health IT algorithms plus clinicians, and being involved in the whole care ecosystem?
Yeah, as I said, I think the doctors' diagnoses are probably easier to replace with AI than the nurses caring. And
when it comes to triage?
And whatever, the whole notion of caretakers being a really important part of the equation is correct. I'm not sure exactly what the question was, but did I answer it?
So when it comes to triage, having the nurse recommendation,
Yeah.
reviewing everything and confirming the recommendation, do you think it's helpful?
Sure.
Okay.
I mean, everything's helpful. The question is compared to what and how well they do it.
Compared to telephone triage, for example, they have to be on the
sure.
phone. Oh, okay. Thank you very much. Appreciate it.
Yeah, and I mean, just in closing,
Sure.
the sort of how nice it is to see people from someplace other than New York and California, how nice it is to see people who are patients as well as people who are caregivers. It's been great. Thank you very much. And thank you, John.
Thank you, and I hope one of your startups does well enough to get you to space.
Thanks.
Thanks, everybody.
Esther Dyson, and a special thanks to the New York Times' John Markoff.